Research Affairs at Memorial Sloan Kettering Cancer Center, and Dr. Daryl Sleep, Head of Global Public Health at Amgen, for a panel with Foreign Policy's Dr. Maisha Alam on tackling non-communicable diseases in low and middle-income countries.
Hi everyone. We're going to be picking up on some of the themes that you heard a little bit about in the previous segment and really zeroing in this panel discussion on health equity when it comes to NCDs in low and middle income countries. And I'm really delighted to have with us Dr. Lazavikan, Dr. Lee, and Dr. Sleep. And each of you represent a really important perspective in terms of how do we ensure that there's equity when it comes to access to care and research and innovation? Bob, I'd love to start with you. And, you know, yesterday was World Cancer Research Day, and I know that this is something that you're very passionate about and have done a ton of work around. And the fact of the matter is that cancer care has drastically advanced over the course of the last couple of decades, and there's plenty of results to show for that. But when it comes to this progress, it's obviously uneven, and especially so when it comes to low and middle income countries. And so help us understand, especially as relates to research and innovation, what explains this discrepancy and this dynamic, and how do we course correct away from it?
Thank you. So as an oncologist, I'm going to zoom in on cancer. And as an Australian oncologist practicing in New York, I'm going to give you a global perspective as well. So really global is local, and that's the solution here. Cancer is still, despite all the molecular biology, genetics, artificial intelligence, this era of technological transformation we live in right now, cancer kills 10 million lives every single year. And apart from other diseases, cancer is one that strikes fear with psychosocial ramifications throughout whole families and your social networks. So this is really a common enemy of humanity. Now, why can't we cure cancer? Because we have to do clinical trials. You have to convert all of those explosion in science into a scientific, rigorous process to convert it to life-saving therapies or prevention. So, and that process takes about 10 to 15 years to even develop a new vaccine or a new drug or a new technology. And largely because fewer than 5% of patients are accessing clinical trials, and largely relegated to elite academic cancer centers like mine, Memorial Sloan Kettering on the Upper East Side of Manhattan. But 95% of patients globally miss out on clinical trials. Now, clinical trials are considered the best care for a patient with cancer to improve beyond what we have today, but into the therapies of tomorrow. But 95% of patients miss out. There's something fundamentally wrong with that. And if we don't course correct this, we're going to be stuck with a process that is investing $80 billion a year with pharmaceutical R&D and then government investment, but fewer than 5% get the access. And you're going to be stuck with a 15-year R&D timeline. We don't have that many 15-year life cycles in our career or our lifespan. Our grandchildren will be stuck with the same. So you have to go to the 95% to change the equation, change the paradigm.
Yeah, and I love the way that you put that so clearly. And when we think about that 5% versus 95% discrepancy, I think it's really important to be bringing in perspectives and lessons from the Global South. And in particular, Namaka, I want to bring you into the conversation here. You are a leading doctor and researcher in Nigeria and across the continent with a wealth of experience. And so help everyone understand, why is there such an urgency to boost clinical research and innovation in places like Nigeria and across the African continent? You know, why is that so important in terms of the results and the operationalization of cancer care?
Yeah, thank you so much. I think Bob inadvertently gave one of the answers in his opening talk. I mean, he says that 95% of the people that don't have it. And then take, for instance, all of the genetic testing that is done, all of the precision medicine that is being birthed. How many of them actually have the African population in it? We're talking about SDG goals. We're talking about health equity. How many of them, you know, can access these drugs? How many of their genomes or genomic specimens are part of the clinical trials that exist? So there is an urgency to have the LMIC and the Global South involved in clinical trials and clinical research. And that's a no-brainer. If we want to improve our health indices globally, we must take them into account. And according to the WHO report, by 2040, 75% of the people that have cancer will be from LMICs. Again, we are driving the disparities and worsening the health equity that we are striving to change at this point in time. So I think that now more than ever is the time to start focusing on building capacity in the LMICs for clinical research, because right now it's time for us to get patients from there, get the diversity that is needed to help drug development, but also strengthen the health system in the LMICs by bringing all of these clinical trials to them.
Yeah, thank you. Thank you for that. And that's fantastic. And I think one of the key messages I'm hearing as I listen to you speak is that it is about the right thing to do, but it's also about the results, right? And what information are you drawing on to devise interventions? Are they representative of who's most affected by the problem, and therefore be able to have targeted interventions that work? And so, Daryl, I'd love to bring you into the conversation at this point, and in particular, as relates to closing the gap between research and action, or research and implementation. From your perspective, what are the kinds of collaborative partnerships that are needed in order to mobilize exactly the kind of change that Bob and Namaka are calling for?
So, a company like ours that has a foundational focus on bringing the latest innovation and the latest best science to the healthcare ecosystem to transform how patients are treated, that's great, and we completely understand and we agree. Less than 1% of all clinical trials are conducted on the continent of Africa, and 90% of those are in South Africa, right? So there's a real opportunity there. The one thing, though, is that, we need to implement the innovation that already exists. So if you think about, medicines like tamoxifen, we're going to focus maybe, because Bob's sitting next to me and is an oncologist, and consider the plight of breast cancer in low and middle income countries in the global south, as an example. So, there's innovative therapies, whether it's trastuzumab, bevacizumab, rituximab, fantastic, innovative, highly impactful medicines that have been developed in those 15-year cycles, but they're not being adopted and they're not being utilized systemically and systematically in the healthcare systems, where they're even available, potentially even on the essential medicines list of the World Health Organization, or even national medicine lists. Why is that? I think there's a big component here of, if we're going to focus on evidence generation, there has to be the healthcare infrastructure and strengthening of the healthcare ecosystem where these medicines need to be adopted. We need to have mechanisms to stage shift the diagnosis into, more effective screening, more effective early diagnosis, more effective intervention in early stages of disease. That takes partnerships across the entire healthcare ecosystem with, people that are the healthcare institutions themselves, governments, government policy, the NGOs that are involved here, so that we can actually then bring these medicines to bear. And for sure, if we can narrow that gap, and if we can actually get these medicines to the patients that need them, and then we can really tackle bringing the innovation and focusing on the precision medicine. But it's going to have to be a staged approach, in my opinion. And so, we really value the partnership that we have with groups like City Cancer Challenge that are looking for local solutions, ground-up solutions, understanding the community-based problems and barriers that are in their way, so that we can actually implement the medicines that we already have.
Well, one of the recurring themes of this conversation, it's exactly where we started with you, Bob, about global and local, right? And you kind of echoed that point as well. And one of the things that you said that I think is really important for us to spend a little time on is when we think about community-led interventions. And Namaka, I'd love to bring you in on this, whether cancer or other non-communicable diseases, and there's so many that are so far reaching, and then the morbidities kind of intersect. So it's really a complex set of challenges. But in terms of, locally led innovations and interventions, tell us a little bit about what are some approaches to strengthening health systems overall, and in particular primary health care systems, that you think are really important in terms of improving health outcomes in low and middle income countries.
Yeah, I think one thing that we can do is to invest a lot in implementation science research, because that is taking the evidence, as it were, and then adapting it to the local community to be able to ensure that the outcomes are the same or even better. Right now, in terms of evidence generation that was talked about, we have a lot of frameworks, we have a lot of theories that supports translation from the bench into the clinics. But do we know if those theories or frameworks would still fit and achieve the same results within our local communities? I'm involved currently in a trial. It's a clinical trial, even though it is non-pharmacologic. But we all know that cervical cancer, the best way is prevention or screening. We have models of how it would be, but as we're implementing, it's an NIH grant on focusing on HIV population. As we begin to implement some of those strategies within the communities, we've adapted quite a bit of these theories and frameworks. So perhaps it's also time to use that to strengthen the implementation science frameworks and theories as well. We need to use that to be able to contribute to the global body of information, because through those adaptations, we begin to understand that there's a dire need for contextualization. There's a dire need for us to adapt. And then at the end of the day, one of the things we want to safeguard is the fidelity. But if we keep adapting, then it brings to mind that we probably have to revamp the system.
I appreciate that, and it makes me think back to some of the comments that you were making, Daryl, in terms of where is innovation happening, and you talked about the City Care Challenge, and that being an example. I know something that, Bob, you've been very, very focused on as well. But another context that comes to mind is Paraguay, where some really interesting work has been happening. So maybe you want to tell us a little bit about kind of what it is that you've been doing there. And if I may preview, Bob, I'm going to go to you next and ask you about how you scale that up, and how do we take it from one context to another but make it locally relevant.
No, thanks for the opportunity. So firstly, I'd want to echo, I think that implementation science is really where we need to go. And interventions are not just pharmaceutical or medicines, it's the intervention that makes sense. So the City Cancer Challenge program, which is a multi-stakeholder partnership that does include a philanthropic component of providing really needed medicines within the healthcare system, is a great example of what I'm talking about in terms of really a ground-up understanding of the specific needs within the healthcare system in order to be able to bring transformative medicines and transformative approaches to the community there. I think where Bob's going to go is that if we can actually conduct these types of interventions, analyze them, or do an implementation science type of evaluation of the intervention that we're bringing, or the solution we're bringing, so that you can scale that everywhere, it's going to be critically important. So the component pieces in Paraguay were, from a ground up, understanding that the mechanism to process the pathology specimens and having an automated digital approach to even tracking the data from the pathology specimens, the ability to actually mix chemotherapeutic agents in a safe environment that doesn't put the healthcare worker or the patient at risk, are some of the examples of foundational problems that needed to be addressed before you can start delivering trastuzumab. So you can't treat a HER2 positive patient with breast cancer if you don't have the ability to do the immunohistochemistry. So putting immunohistochemistry facilities and capabilities into that healthcare system was foundational. So there's so much that can be done, but it's not a one-size-fits-all. It's not about bringing a pre-packaged solution and dumping it into that system. It's working with the community workers, the healthcare workers, the community at large on the needs. The inspiring thing about this, just finally, is that, you know, the system and the people working within the system, there's a passion and a drive, but we move from a tolerance of the problem to an enthusiastic drive to sustain the change by relatively simple, didn't cost a fortune, didn't take a lot of heavy lifting to do this, but foundational changes. And the more we can actually learn from that and scale it through a sort of systematic approach to generating the evidence of the benefit, I think we'll be able to bring sustainable solutions across low and middle income countries.
Well, and to your point about contextually relevant, Bob, I'd love to bring you in on this, which is, you know, I really appreciate what you said, Daryl, that it can't just be a one-size-fits-all. Somebody parachutes in, they think they've got the magic bullet, they deliver it, and they're gone. It's not how it works. It's just not how change happens. And so, Bob, you've worked in so many different contexts, and, you know, help us, you know, close out this discussion by focusing a little bit about how do we make sure that as part of scaling up, we are remaining geographically and culturally relevant, that we are leveraging the kind of evidence that Nomaka was talking about, that represents and is informed and shaped by the population that is supposed to be receiving the care.
Absolutely. So I'm just building on Daryl's excellent point about multi-stakeholder collaboration. That's essentially the solution, the key to getting it done. It has to be a collaboration with multiple stakeholders in the ecosystem. I'm an academic. You know, I write grants and papers and write protocols, but that's still fundamental to my work, but it's insufficient to cure cancer. We have to work with governments, we have to work with industry, we have to work with philanthropists, we have to work with business, we have to channel investment. This is a global ecosystem that requires everybody moving towards that North Star together. And there could be a myriad of ways in terms of implementation, but we all have to move in that direction. And everybody has a role to play. Spread the word, the importance of clinical trial, the importance of access for the 95%. So then you have synergy. Then you're going to see the needle moving in the global, at the global scale. So one example, the Paraguay story is really amazing. And we can do that at scale with, you know, really every country. I just came back from Abuja as invited by the Nigerian government, co-hosted with NICRAT, Namaka's institution, and also the Nigerian Sovereign Investment Authority. They're investing, their government sort of sovereign wealth fund, investing in cancer-centered establishments, and where MSK my institution is helping in terms of capacity building, channeling clinical trial investment, through biopharmaceutical industry partnerships. And my colleague Peter Kingham, who's been on the ground for more than 10 years, partnering locally, is also synergizing with this effort. And now we're starting to see that this is actually doable. We could actually set up clinical trials in Nigeria, in Lagos, in Abuja, in Ife, in many other places, hopefully the rest of Africa by extension. And we're actually discovering things we would not otherwise find in New York City. You know, those who are familiar with the cancer space, MSK had developed this cure for a subset of colorectal cancers with this genetic signature called MSI high or MMR deficient. Now, it's very rare. It's like, in practice, it's like 2%. It's really how we've spent years just to catch the 20 patients to put them on trial to demonstrate this cure. But in Nigeria, it turns out 30% of colorectal cancers have this signature. So that's a swath of the population. And these are young women and men in working, productive life, suddenly got this horrible disease that's going to otherwise debilitate and kill them. You have a cure that it's actually readily available. And by channeling public-private partnership and multi-stakeholder collaboration, you can eliminate 30% of colorectal cancers in that country. And let that be a shining light and as an example for the rest of the world. You know, so these are sort of things that we otherwise would not be able to do in just New York City alone. You know, despite being it's a big melting pot, it's a big capital of the world and so forth, you just can't do it here. You need that global collaboration and the diversity of patients, diversity of biology, and then you come back and bring that knowledge home and support your local community. So you can't just wait until our backyard is all fixed before you go out. That's more of a colonial approach. It's not like that anymore. Those days are gone.
And it doesn't work, to your
it doesn't
point.
work.
Yeah.
You got to learn from afar and bring it back through. This is the age of technology. You bring it back, you cure your patients who are underserved in the minorities, the rural patients, really the patients who miss out in America, they need help as well. But global is local, and that's how we got to get it done.
Well, thank you for that. And wow, I love that particular example from Nigeria, and I think it's so illustrative of what you were, Namaka, emphasizing at the beginning of our conversation, why it's so important that we be investing in that research, those trials, because otherwise you're not only missing out on a patient population that needs it, but that you can learn from and make all of the interventions that much more effective. Well, thank you, Daryl, Bob, Namaka. It's a real pleasure to be with you all, and thank you for sharing your perspectives. I know this is a really difficult set of topics to discuss, and you work on them every day, but I certainly am leaving this conversation feeling hopeful, so thank you for that.
Thank you.